Hi everyone, welcome to my YouTube channel. I am Dr. Rajiv, specialist in physical medicine and rehabilitation. Let us begin solving these MCQs.
This video is a sequel to the one I previously uploaded, which features an MCQ discussion about various types of hand splints. Please watch it. Okay, let's check out the questions here. Which one among the following images is a dynamic splint? There are four alternatives: A, B, C and D. This is the same image, views from different angles. B is the second alternative. Take a close look at this image. This is the option D. The same splint worn on the finger. The correct answer is D, Kapner splint, which is a dynamic splint. Kapner splint is used in the treatment of buttonhole or boutonniere deformity. Boutonniere deformity is characterized by flexion of the PIP joint and hyperextension of the DIP joint. Kapner splint is a dynamic splint, as I have already mentioned. It has a spring which helps in moving the finger at the same time keeping the deformity corrected. Norman Kapner pioneered the use of such types of splints in clinical practice. Pathoanatomy of boutonniere deformity. A central slip injury commonly results from trauma leading to boutonniere deformity. This deformity may also occur in rheumatoid arthritis and burns. Disruption of the central slip results in imbalance of the extensor mechanism, leading to volar displacement of the lateral bands. With assistance from the intrinsic muscles, the central slip carries the direct pull of the extensor digitorum communis tendon onto the PIPJ. The central slip, which is the primary extensor to the PIPJ, lies just beneath the dermis on the dorsum of the hand at the PIP joint. The gradual transition between the tendon and the bone at the insertion point, the enthesis, and the shallow angle of attachment contribute to its strength but also complicates its rehabilitation either conservatively or surgically in terms of stress tolerance and scarring. Established deformity cases may present with a flexion contracture of the PIP joint and absent flexion of the DIP joint due to shortening of the retinacular ligaments. I was curious who named this injury a boutonniere or buttonhole-like. The search was interesting and I could find only these two references. Bingham and Jart article is titled with buttonhole in inverted commas, as you might have noticed already. So this could be the first instance where this injury was called boutonniere. Anyways, if anyone of you can throw more light into this, please comment. Boutonniere in French or buttonhole in British English is a single flower or bouquet worn on the lapel of a tuxedo or suit jacket. The injury might have gotten its name because of the wound's resemblance to a buttonhole. The proximal flanks may buttonhole through the wound. Just for fun. This is a mnemonic made by myself. Boutonniere deformity is characterized by pathological flexion of the PIPJ and extension of DIPJ. Bowflexing produces an extensive dip in the level of unhappiness. There are different protocols for the use of splints, such as Kapner splint for boutonniere deformity. However, it has a definite role in the treatment of central slip injuries, albeit with varied protocols. Please note that this is not the only splint that is being used in this condition. In the non-operative treatment, Static volar finger splinting is given for only the PIP joint for the initial 4 or 6 weeks for an acute closed injury, and weaning off from this splint is done with the use of a volar night splint for a further 2 to 4 weeks or more if needed, and a capron splint during the daytime or while undergoing hand therapy. Dynamic splinting is sometimes given post-operatively as well. It may be around 4 to 6 weeks when hand therapy commences. In neglected, established cases, this splint is sometimes used to improve the joint mobility pre-operatively as well as while undergoing a comprehensive hand rehabilitation program. Let's now discuss the other alternatives given in the question. This is a long thumb splint. It's a static splint. There are no mobile components seen anywhere on this splint. This splint is indicated as an extension stop for the distal phalanx and when controlled mobility of the CMC and MCP joints is required. The long thumb splint is used in thumb sprains, after tendon surgery to limit extension of the thumb, in basal joint arthritis to minimize pain, and sometimes in decurrent stenosynovitis. The next alternative in the question was an upper extremity prosthesis. A prosthesis, as you know, is an artificial substitute for a missing body part. The field of prosthetics is very advanced now with innovative features both for upper and lower extremity prosthesis. Next, mallet finger splints. As stack splints are widely used in the non-operative management of mallet injuries. A lot of people have mistaken this injury's resemblance to an ordinary mallet or hammer, but such tools have projections on both sides. The injury is named like this because the mallet finger resembles the hammer or mallet of the piano tuning keys, with a peculiar one-sided bend at its tip. We have covered already the central and lateral slips of the extensor digitorum communis. The central slip inserts onto the middle phalanx while the lateral slips coalesce with the tendons of the interosseous and lumbrical muscles to form the lateral bands. The lateral bands then cross the DIP joint to insert as the terminal tendon on the dorsal epiphysis of the dorsal phalanx. Disruption of the extensor tendon at the level of distal phalanx leads to loss of terminal extensor function at the level of DIP joint of the fingers or thumb. Patients present with a painful or painless deformity and inability to fully extend actively the DIP joint. The injury can be purely tendinous or with a bony component. Mallet finger is also known as baseball finger or drop finger. Avulsion of a bony fragment, bony mallet. This is a soft padded aluminum splint with velcro straps used in the mallet finger treatment. Here a slight extension is provided to the DIP joint. This is another type of splint made with low temperature thermoplastics. Perforations help in ventilation. Splinting is advocated for closed mallet injuries even if presented late, even up to 3 to 6 months, provided there are no indications for surgery. However, surgical correction may be required in volar DIP joint subluxation, and if more than 30 to 50% of the articular surface is fractured, non-compliant patients, and failure of non-operative treatment. Open injuries invariably require operative intervention. For splinting to work, the patient must be compliant. Splint use must be consistent throughout the day and night up to 8 weeks, and regular follow-up is essential to adjust the splint, take care of skin problems, and if needed, change of the splint to another type. Joint protection principles must be observed meticulously by the patient. Continuation of splinting is sometimes advised even after 8 weeks, specifically during sleep and manual work until full recovery. The next question is, what is the name of this splint? A. Silver ring splint. B. Oval edge splint. C. Frog splint. D. Yoke splint. The correct answer is oval 8 splint. It resembles the shape of the digit 8. This splint can be used in Boutonniere deformity. It can also be used in Swan neck deformity. We have already discussed about the dynamic Kapner splint which can be used in Boutonniere deformity. One of the alternatives given in the question was silver ring splint. This is made of metal. This is almost the same like the oval 8 splint. These two splints are used in cases of rheumatoid arthritis for correcting deformities such as Boutonniere deformity and Swan neck deformity. These are often used by rheumatoid arthritis patients. Swan neck deformity is characterized by hyperextension of the PIP joint and flexion of the DIP joint. Use mnemonics as an active learning strategy. Be creative. I made this to facilitate active learning. Swans enjoyed the Proxima hypermarket chips dipped in flex sauce. As you know, Swan neck deformity is characterized by proximal interphalangeal joint hyperextension and distal interphalangeal joint flexion. This is called a frog splint. This static splint made of a malleable aluminum is sometimes used in the non-operative management of phalangeal fractures or minor finger sprains. Yoke splint was an alternative given in the question. This splint has gained a lot of attention in recent times as a means of providing support to the repaired extensor tendon of the hand in the post-operative period. A yoke, as you might have guessed, is a frame used in bullock carts. A yoke splint. The position of the MCP afforded by this splint reduces the forces across the repaired site, preventing tendon rupture. Besides, it reduces the rehabilitation time. This yoke splint or relative motion orthosis was fabricated using a 3.2 mm perforated thermoplastic sheet, keeping the middle finger extended at 20 degrees relative to the MCP of the other fingers. This orthosis allows a full flexion of all the joints of the other fingers and the PIP and DIP of the middle finger as well. The preferred name for the splint as of now is relative motion extension orthosis or relative motion flexion orthosis, as this can be used after flexor tendon repair as well. In this case, the MCP is kept flexed. In the past, so many names had been given for this orthosis, including Merit splint, to honor him for the invention of this splint. However, it was a wonderful initiative by Herth et al. To use the term orthosis bar orthoses instead of splint bar splints, as this is considered the accepted current nomenclature. As I have mentioned in the previous video, the nomenclature of hand splints can be confusing at times. According to Shaw et al., there is now good evidence that the relative motion approach is safe in zones 5 and 6 for extensor tendon repairs. Limited evidence currently exists for zones 4 and 7 extensor and for flexor tendon repairs. Variability in the use of a relative motion orthosis, such as only RMO or RMO plus, that is with its extension, use of sleep time resting orthosis, differences in orthotic wearing schedules, etc. pose difficulty in research, thus limiting the external validity. There are reports of its effectiveness in Boutonniere deformity and sagittal band repair. However, high-quality studies that contribute to the evidence base for its use in these cases are needed. Despite all this, the use of this splint is widespread. Let's end this video here. Thanks for watching this video. If you like it, please give a thumbs up. Feel free to share it and subscribe to my channel. Bye.